Hello, I'm Professor Mehmet Ayhan Kuzu from Ankara University, Ankara, Turkey. In this section, I will present animation clips to describe complete mesocolic excision concept. Before I start, please allow me to thank an extremely talented group of animators. Their designs not only made the learning process more effective, but also an easier task for surgeons of all generations. Briefly, the concept of surgical approach for complete mesocolic excision is the consequent surgical separation by sharp dissection of the visceral fascia layer from the parietal one, resulting in complete mobilization of the entire mesocolon covered by intact visceral fascial layer on both sides, ensuring safe exposure and tie of the supplying arteries at their origin. Standardization of colon cancer surgery with sharp dissection following embryological anatomical planes has been reported to improve oncological outcomes. Since the extent of colon cancer surgery was determined by the localization of the cancer and the pattern of the potential lymphatic spread, I will review complete mesocolic excision for each colonic localization separately in the following animation clips. This animation reviews the complete mesocolic excision for sickle and ascending colon carcinoma. Regarding the lymphatic spread, metastatic nodes are first located in the pericolic area, but this spread is no more than 10 cm from the primary tumor, then into the lymph nodes following centerwards, the supplying arteries. Therefore, the extent of lymph node dissection includes iliacolic artery, right colic artery if present at all, and the right branch of the middle colic artery with dissection of the lymph nodes along the route of the middle colic artery. This way, all the potential lymph nodes within 10 cm distal to the tumor must be removed. This diagram presents the surgical resection margins. In order to enter the correct surgical plane between the parietal and the visceral peritoneum, the traction of the peritoneum lateral to the tumor is our dissection. Lateral peritoneal reflection is being divided, not too close to the tumor. We must always preserve the circumferential surgical margins. Sharp dissection following embryological anatomical planes has been reported to improve the oncological outcomes and therefore crucial for precise surgery. Parietal plane is exposed, and by sharp dissection and traction and contratraction, the ascending colon is taken from the parietal plane with preservation of the ascending mesocolon. Here you see areolar tissue. The duodenum and the pancreas is fully mobilized. Following the elevation of right colon together with the radix mesentery, dissection is proceeded in the cephalic direction until the inferior mesenteric vein is encountered behind the fourth part of the duodenum. Trice ligament and the mesentery is now divided, which brings the colon and the tumor even more forward. Full mobilization of the mesenteric root allows us to control the superior mesenteric vessels and to have an easy access to the tumor and mesocolon in front of the abdominal wall, not deep in the abdominal cavity, get free access to the central vessels which make the operation safe. Within this embryological plane, we encounter ureter, gonadal vessels, inferior vena cava, and the aorta under the parietal fascia surrounded by retroperitoneal loose tissue. To remove the potentially metastatic lymph nodes and achieve central vascular ligation, the attachment of the mesenteric plane covering the duodenum and the uncinate process were taken down from the corresponding one of the mesenteric root to get full access to superior mesenteric vein and the artery behind. In order to prevent bleeding, traction of the mesocolon must be done carefully during the separation of the mesocolon from the pancreas and the duodenum. Superior mesenteric vein and its branch are seen in this animation. Superior mesenteric vein is covered by mesocolon. If you want to get access to this vessel centrally, you have to incise the mesocolon too. The bleeding point is very important to realize. This is the area to watch the veins carefully and not to tear them. We have to ligate any colic veins that cross the superior mesenteric vein. Otherwise, the application of the traction might result in tearing these veins. Therefore, we ligate the right colic vein and the superior right colic vein first, then to an access to superior mesenteric vein. Superior mesenteric vein is now fully exposed. We extend the exposure over the superior mesenteric vein about 3 to 4 cm beyond the origin of the ileocolic vein. This maneuver allows us to split the mesentery safely and prevent incorrect ligation of the jejunal trunk as ileocolic vein. Bear in mind that 30% of the cases the ileocolic artery is crossing the superior mesenteric vein from the below. Then you expose it first before you get access to superior mesenteric vein. Following the transection of the distal ileum 10 to 15 cm proximal to the ileocecal wall, the mesenterium is splitted down to superior mesenteric vein. Then, middle colic vein and the middle colic artery is exposed. For the cancers of the cecum and ascending colon, only the right branches of the middle colic vessels are divided centrally. By doing so, following the 10 cm rule, all potential lymph nodes metastases will be removed. So, the transverse colon was divided right at the level of middle colic vein. The resection line will be followed. Mesentery is split. All the lymph nodes are removed. The transverse mesocolon is transected. Since the momentum is more than 10 cm away the tumors in cecum and the ascending colon, there is no need to remove the momentum with the specimen unless it is attached to the tumor-bearing area. Right side of the momentum is taken off the colon by following the areolar planes. This is the end of traction before the small and the large bowel is divided, so the entire lymphatic field is cleared and the planes are well preserved. Now, I will review the complete mesocolic excision concept for hepatic flexural carcinoma. This diagram shows the surgical margins for hepatic flexural carcinoma. The extent of lymph node spread is different in hepatic flexural carcinoma compared to ascending colon and cecal carcinomas. In addition to the lymphatic clearance in ascending colon carcinomas, about 5% positive lymph nodes can be found over the head of the pancreas and 5 to 8% lymph nodes along the gastroeploic arcade at the greater curvature of the stomach. Therefore, the greater curvature of the stomach should be freed 10 to 15 cm from this arcade opposite to the tumor site at the hepatic flexura. One must also bear in mind that Hepatic flexural carcinomas may also metastasize into the lymph nodes along the inferior edge of the pancreatic corpus as well. Following the division of the lateral peritoneal reflection, sharp dissection within the areolar embryological planes allows us to mobilize ascending mesocolon, as we did in the previous section for cecal carcinoma. The dissection plane is created by traction and contratraction. Care must be taken not to tear the mesenteric planes. Elevating the right colon together with the radix mesentery, dissection is proceeded in the cephalic direction behind the fourth part of the duodenum. Full mobilization of the mesenteric root allows us to control the superior mesenteric vessels and to have an easy access to the tumor and the mesocolon. Hence, we get free access to the central vessels, which make the operation safe. As delineated before, lymphatic spread to the pericolic lymph nodes can be found within 8 to 10 cm from the primary tumor, but no more than that. Therefore, the greater curvature of the stomach was freed 10 to 15 cm from this arcade opposite to the tumor site at the hepatic flexura. This also removes the positive lymph nodes along the right gastroepiploic artery. Greater momentum is therefore resected en bloc with the specimen. In order to remove the lymph nodes around the pancreas and the pylorus, en bloc resection of the mesocolon with the greater curvature is performed. To get free access to the superior mesenteric vein, the duodenum is taken down from the ascending mesocolon. Traction and contratraction allows us to mobilize the duodenum, and the parietal plane is well preserved. Separation of the mesocolon from the pancreas is completed. Now we get close to the mesopancreas. Please note that superior mesenteric artery and its branches are encountered behind the superior mesenteric vein. Ileocolic artery and right colic artery originated directly from the superior mesenteric artery. Rarely, as in this case, ileocolic artery passes underneath the superior mesenteric vein. In such cases, following the elevation of the mesocolon, ileocolic artery appears before the ileocolic vein. Then, ileocolic artery is ligated, followed by central ligation of the ileocolic vein. At this point, traction of the mesocolon may damage veins at the bleeding point. Therefore, any vessels that cross the superior mesenteric vein must be ligated first. Here, the branch of gastroduodenal artery, right gastroepiploic artery, is visualized. Right gastroepiploic artery is ligated just below the pylorus. As you know, right gastroepiploic vein drains into Henle trunk. Proximally, Henle trunk is formed by anterior superior pancreaticoduodenal veins, right gastroepiploic vein, and superior right colic vein. Please note that variations exist, especially the venous drainage of the right colon are complex. These variations are explained in detail in the anatomy section. Following this, gastrocolic trunk of Henle is ligated. Middle colic vein and middle colic artery can be approached by further proximal dissection along the superior mesenteric vein. However, here we show another way for central ligation of the middle colic vessels. Following the transection of the ileum approximately 10 cm proximal to the ileocecal valve, mesocolon is separated at the level of the ligated vessels along the superior mesenteric vein. At this stage, middle colic vein and middle colic artery are ligated and transected. Autonomic nerves around the superior mesenteric artery must be preserved at this point. One must also bear in mind that hepatic flexural carcinoma may also metastasize into the lymph nodes along the inferior edge of the pancreas as well. Therefore, lymph nodes removal along the inferior border of the pancreas is crucial. Transverse mesocolon is then dissected from the anterior margin of the pancreas. Finally, the specimen including the central vascular ligations and the lymph nodes are demonstrated. It will be followed by end-to-end anastomosis. Here, complete mesocolic excision concept for transverse colon carcinoma will be shown. This diagram delineates the surgical margins. At the beginning of the procedure, the dissection planes are similar to the hepatic flexural carcinoma that includes the lymph nodes clearance around the superior mesenteric artery, the pancreas, and the lymphatics of the inferior edge of the pancreas, as well as the nodes along the gastroepiploic arcade at the greater curvature of the stomach. The rationale for pancreatic lymph node dissection in these cases is collateral circulation. There are small vessels connection between the transverse mesocolon and the pancreas and the gastroepiploic artery along the stomach. These small vessels are important because they are joining to the pancreatic vessels. These lymph nodes may be metastatic on the lower border of the pancreas. Therefore, the dissection is important at the lower border of the pancreas by sharp dissection. For mid-transverse colon cancer, due to the arcade principles, both flexures have to be removed with lymphatic clearance. As mentioned previously and encountered here, the dissection planes are same with the hepatic flexural carcinomas. Since there will be no lymphatic spread along the ileocolic vessels, there is no need to remove the ascending colon. However, even for the left-sided transverse colon carcinoma, it is very helpful, even necessary, to mobilize ascending colon as well, as I did for the ascending colon carcinoma. Because following the removal of the specimen, the anastomosis between the ascending colon and the descending colon, ascendo-descendostomy, is not practical and may create morbidity. Lymph nodes around the superior mesenteric vein are removed with the central vascular ligation, as we did for cecal and hepatic flexural carcinomas. In addition to this, whole gastroepiploic arcade together with the greater omentum is included within the specimen. Rarely, as in this case, ileocolic artery passes underneath the superior mesenteric vein. In such cases, following the elevation of the mesocolon, ileocolic artery appears before the ileocolic vein. Then, ileocolic artery is ligated, followed by central ligation of the ileocolic vein. At this point, traction of the mesocolon may damage veins at the bleeding point. Therefore, any vessels that cross the superior mesenteric vein must be ligated first. Here, the branch of gastroduodenal artery, right gastroepiploic artery, is visualized. Right gastroepiploic artery is ligated just below the pylorus. As you know, right gastroepiploic vein drains into Henle trunk. Proximally, Henle trunk is formed by anterior superior pancreaticoduodenal veins, right gastroepiploic vein, and superior right colic vein. Gastrocolic trunk of Henle is ligated. Middle colic vein and middle colic artery can be approached by further proximal dissection along the superior mesenteric vein. However, here we show another way for central ligation of the middle colic vessels. Following the transection of the ileum approximately 10 cm proximal to the ileocecal valve, mesocolon is separated at the level of the ligated vessels along the superior mesenteric vein. At this stage, middle colic vein and middle colic artery are ligated and transected. Moreover, splenic flexure is mobilized in order to remove the lymph nodes along the left colic artery. Therefore, the mobilization of the left colon is essential. Then, the left colic artery is ligated at its origin. This is followed by the ligation of the inferior mesenteric vein next to the duodenum, just underneath the pancreas. Finally, the specimen includes the central vascular ligations and the lymph nodes are demonstrated. It will be followed by end-to-end or side-to-end anastomosis. In this section, I will review the complete mesocolic excision concept for splenic flexural carcinoma. Splenic flexural carcinoma is a borderline localization because of the bidirectional lymph node spread. One side is the middle colic vessels, on the other end, towards the inferior mesenteric artery. This cancer, therefore, can be treated left or right-sided approach. However, in most cases, left side concept is better. Following figures presents the borders of the oncologic resection margins. Regarding the lymphatic spread, metastatic nodes are first located in the pericolic area, but this spread is no more than 10 cm from the primary tumor, then into the lymph nodes following the centerwards, the supplying arteries. The main arteries are the middle colic artery and the left ascending colic artery. In addition to this, the removal of the nodes along the inferior aspects of the pancreas and the arcade principle has to be followed. This includes the removal of the lymph nodes along the gastroepiploic arcade at the greater curvature of the stomach as well. In order to prevent complications regarding the transversodescendostomy anastomosis, the other option for the splenic flexural tumors is subtotal colectomy and iliodescendostomy. And splenic flexural carcinoma can also be treated like a left side colon cancer. Extended left hemicolectomy can be performed. Here, left-sided complete mesocolic excision approach for splenic flexural carcinoma is animated. In order to remove both the pericolic lymph nodes and the gastroepiploic lymph nodes, left side of the transverse colon and the greater curvature of the stomach should be freed 10 to 15 cm from this arcade opposite to the tumor site at the splenic flexura. This allows us to remove the omentum with the specimen as well. The dissection starts with the scatellization of the stomach. transverse colon, and the gastroepaulic arcade are prepared, and en bloc resection of the mesocolon with greater momentum is planned. Following full separation of the transverse mesocolon, laser sac is fully exposed. The lymph nodes along the inferior edge of the pancreatic tail are also dissected. Then, ascending colon is mobilized as shown previously. However, if segmental resection is planned, there is no need to central vascular ligation of the ileocolic vein and the right colic veins. However, central vascular ligation of the middle colic vein are crucial. This maneuver allows us to remove the lymph nodes around the middle colic vessels. As mentioned before, up to 4 to 6% of lymph node metastasis can be detected at the root of the middle colic artery. Following the completion of the central ligation of the middle colic vessels, full mobilization of the splenic flexure and the descending colon are performed. Similar dissection within the embryological planes is followed during this maneuver. Then, the descending colon is transected at least 10 cm distal to the tumor. Then the lymph nodes around the inferior mesenteric artery are removed and its first branch, left colic artery, is ligated. Inferior mesenteric vein is ligated at the border of the pancreas. Mesocolon and transverse colon together with the omentum is transected. And finally, specimen is removed. Now, I will demonstrate the complete mesocolic excision for descending colon carcinoma. The extent of lymph node dissection for descending colon carcinoma is different than splenic flexural carcinoma. There is no need either scalpelize the stomach or remove the omentum if the descending colon carcinoma is located 10 cm away from the flexura or there is no direct invasion to these structures. This figure represents the dissection borders. The mobilization of the splenic flexure is essential for descending colon cancer for a tension-free anastomosis. Once the entire mesocolon of the descending colon and the sigmoid colon were dissected off the retroperitoneal plane, animations shows the retroperitoneal structures, perirenal fat, ureter, gonadal vessels, which is covered by the parietal fascia. The greater omentum is detached from the transverse colon for full exposure of the laser sac and subsequent division of the two layers of the transverse mesocolon at the lower border of the pancreas. During splenic flexure mobilization, we have to keep very close to the bowel wall and avoid the damage injuries to the spleen. Throughout these preparations, the integrity of the mesocolon should be strictly preserved. In order to achieve lymph node clearance around the root of the inferior mesenteric artery, visceral peritoneum over the aorta is opened. The lymph nodes around the inferior mesenteric artery are dissected and the inferior mesenteric artery ligated within the 1 cm to the root of the aorta. But we have to watch carefully to the autonomic nerves. The next step is the transection of the inferior mesenteric vein to get adequate length to bring down the descending colon to the upper rectal turret for anastomosis. Then the specimen is prepared. The proximal transection line must be 10 cm away from the edge of the tumor. However, the distal line must be at the upper rectum due to the central ligation of the inferior mesenteric artery. Here, I will describe complete mesocolic excision concept for sigmoid colon carcinoma. Similar dissection planes are followed for sigmoid colon cancer as we did for descending colon carcinoma. As mentioned earlier, splenic flexure mobilization is essential unless there is a redundancy in descending colon. Left peritoneal reflection is divided and the sharp dissection between the visceral and the parietal planes is performed. Once the entire mesocolon of the descending colon and the sigmoid were dissected off the retroperitoneal plane, the ureter, gonadal vessels, iliac, and autonomic nerves are encountered, covered by the retroperitoneal fascia. Then the visceral fascia over the aorta is opened. This allows us to open a window at the base of the sigmoid mesocolon while preserving the autonomic nerves. Through this window, inferior mesenteric artery is liberated. Utmost care has to be taken to protect the autonomous nerves while ligating the inferior mesenteric artery close to the aorta. In order to achieve this, the artery must be ligated at a point just 1 cm distal to this root. Further cephalic dissection next to the duodenum allows us to find the inferior mesenteric vein. Inferior mesenteric vein is ligated, divided on the lateral side of the duodenum in order to tract the colon more inferiorly to have a tension-free anastomosis. Right after this step, to make descending colon transection, mesocolon is divided and the lymphovascular pedicle is prepared. In order to prepare the lymphovascular pedicle, specimen, the first branch of the inferior mesenteric artery, left colic artery, is ligated and divided. When the mesocolon is retracted at this level, inferior mesenteric vein is ligated and divided for the second time. Then the descending colon is transected at least 10 cm proximally with intention to remove all pericolic lymph nodes. Following the preparation of the lymphovascular pedicle, the sigmoid colon and rectum is retracted anteriorly and sharp dissection is carried out under direct vision. Since inferior mesenteric artery is ligated, distal margin is located up to upper rectum for both oncological reasons and for the blood supply, provided that distal margin is more than 10 cm to the lower edge of the sigmoid cancer. However, regarding the distal sigmoid cancer, partial mesorectal excision can be undertaken. For distal sigmoid cancers, 5 cm of the mesorectal free margin are adequate. So, partial mesorectal dissection takes the original mesorectal dissection plane again. The surgeon proceeds between the presacral fascia and the fascia propria recti. To obtain at least 5 cm of mesorectal free margin, distal dissection has to be no less than 8 to 10 cm. Otherwise, coning will cause an inadequate mesorectal excision. A common mistake is proceeding just 2 cm from the distal margin of the tumor. This resection attempt is conization indeed and may leave malignant cells behind. Therefore, distal intramural margins are to be ignored and dissection plane to cover 5 cm of free margins within the mesorectum should be aimed.